to welcome you to our webinar on female athlete knee injuries. Today we have a panel consisting of multiple members representing several disciplines from our women's sports medicine program at Mass General Brigham, primarily from Mass General Hospital, Brigham and Women's, and Spalding. And so we are going to be covering multiple topics surrounding the care of knee injuries in our female athletes, covering multiple perspectives in a multidisciplinary setting. So what we can do in the interest of time is I think I'll introduce each speaker as they pull up their talks, and we'll have some time for panel discussion at the end, so please feel free to send in your questions as well. So first up, Dr. Berkson, if you want to share your slides. We have Dr. Eric Berkson, who is an orthopedic surgeon and a colleague of mine at Mass General Hospital. He's going to be talking about sex differences and considerations in ACL surgery.
Sorry, 1 second. Okay. Thank you so much, Dr. Tanaka, for the invitation to speak today. We're going to start by talking about sex differences and considerations in ACL surgery. No disclosures. These differences are large and have been unsuccessfully addressed to date. Meta-analyses and large cohort studies consistently demonstrate a higher ACL incidence in females. Women have a 1.5 to 8 times greater risk of injury to the ACL. And this disparity becomes most pronounced after puberty and is particularly evident in cutting and pivoting sports and in adolescence, where a meta-analysis of 29 studies in adolescent ACL injuries showed a 4 times relative risk of ACL injury in basketball in females compared to males, and a 3 times greater risk in soccer. After ACL reconstruction, females tend to report inferior subjective and functional outcomes compared to males, and most studies have demonstrated a lower return to sport rate. Bruder found a 25% reduced odds of returning to sport, with women under 19 having a 32% reduced odds of return to sport. Return to pre-injury level of sport is also lower in women. This is likely due to both physiological and psychological reasons. We know that women have greater psychological distress than males. Females have lower risk tolerance and greater fear of re-injury. There's also a lower psychological readiness to return to sport, particularly in the early postoperative period. Additionally, national database studies indicate that females are at higher risk for new onset anxiety and depression following ACL reconstruction compared to males. In my own patients, last year I found a 100% eating disorder rate in my under 16 female cohort. Eating disorders themselves have not been found to be higher in ACL injuries in women, but eating disorders are more prevalent in females than males, especially in those high-risk sports. Women also have more recurrent ACL injuries and high failure rates after an initial repair. This 2018 study by Gans found that female NCAA athletes in gymnastics and soccer have the highest rates of recurrent ACL injury, with soccer showing an almost 4 times greater risk of re-injury than males. There's many explanations for this increase in ACL injuries. Some studies attribute this to anatomic differences, including the narrowness of the notch. Women are more likely to have a narrow notch, which can impinge on the graft. The alpha angle is the angle between the long axis of the femur and Blumensatz's line and tends to be increased in females, and women have an increased anteromedial ridging of the intercondylar notch, which also increases this impingement of the graft against the notch, potentially leading to failures. Females have other anatomical differences, including greater chance of having an increased tibial slope. A factor by itself predisposes to increased forces on the ACL. And females also have smaller ACL cross-sectional areas and low ligament volumes compared to males, even after adjusting for body size. This results in higher stress in the ligament for a given load and less capacity to resist an injury during high-demand activities. This size discrepancy becomes more pronounced after puberty as ACL growth plateaus earlier in females, while body mass and dynamic loading forces continue to increase. Hormonal factors have always been theorized to have an effect on ACL risk. We know that the menstrual cycle is unlikely to have a clinically meaningful effect on knee laxity, but we also know that estradiol and relaxin affect ligament properties, and certainly hormonal changes associated with oral contraceptive use, pregnancy, and menopause may alter ligament mechanical properties. There is a largest consensus that neuromuscular risk factors for ACL injury probably account for the greatest difference in risk factors for women. Deficits in lower extremity muscle strength, especially the hamstrings and glutes, poor core stability, altered muscle activation patterns, and suboptimal landing and cutting biomechanics all play a role. So when we are considering ACL surgery, we try to consider all of these choices. Early prehab neuromuscular training and evaluation by an experienced physical therapist is instituted. Just like all patients, early reconstruction may prevent further meniscal injuries. Graft choice can be very important. Bone tendon bone autografts have a lower failure rate than hamstring autografts, particularly in the youngest and most active female patients. There are some studies which indicate delayed or incomplete quadriceps recovery strength, hop test asymmetry, and early extension deficits in females when using a quadriceps tendon autograft. Overall, though, long-term functional outcomes, knee stability, and return to sport rates are similar between all graft types. It's important to make sure grafts are sized large enough to sustain high levels of stress, but not too large for the patient's anatomy. Intraoperatively, an appropriate notchplasty, especially when the narrowed notch is present, is important. We focus on an anatomic reconstruction, repairing the meniscus when possible, and even considering meniscal transplantation or osteotomy in revision cases where the tibial slope is a consideration. We commonly augment the reconstruction to include a lateral extraarticular tenodesis to shield the ACL graft during recovery. And finally, as we'll hear about in the rest of today's talks, it really takes a team approach for surgical success. This usually begins with patient-specific rehab focused early on knee extension and patellar mobility, and continues with a milestone-based approach to physical therapy where quadriceps recovery, formal strength testing and monitoring can be regularly emphasized. And of course, the team at Mass General Brigham includes sports psychology and nutritionists whenever possible. Any talk on sex differences in ACL injuries is not complete without recognizing that neuromuscular training programs can successfully reduce ACL injuries in female athletes, and these programs are really important considerations before and after surgery. So the take-home points today is really a recognition for the individualistic approach that ACL surgery requires, with an appreciation for the psychological and neuromuscular differences, along with a team approach to rehabilitation, recovery, and prevention. We all look forward to future advances in understanding and optimizing these approaches. Thank you.
Great. Thank you so much, Dr. Berkson. That really kind of covers and lays the framework for a lot of what we're going to cover today in terms of the multidisciplinary approach and so many of the considerations that are an individualized approach that tends to fall along sex or gender lines. So thank you so much for that talk. Next up, we have Dr. Kendra Becker. Dr. Becker is the Director of Women's Sports Psychology in our Women's Sports Medicine program, and she's been spearheading a lot of the work in the postoperative recovery and the psychology associated with this. Her talk today is going to be on the psychological considerations for recovery after knee surgery in the female athlete.
Thank you so much, Dr. Tanaka, for asking me to be here and to be able to speak about this topic. I'm really excited to be sharing some of the things we've been doing and learning about the recovery process for female athletes. So this slide is kind of superfluous given the wonderful introduction. I couldn't have been teed up better than Dr. Berkson did for me during this talk. But I just want to remind everyone once again that certain knee injuries occur more in female athletes, in particular ACL injuries, and that there could be a lot of reasons for this that Dr. Berkson already shared with us, but one that I'm going to keep coming back to and talking about is also important in psychological health is menstrual abnormalities, which may affect things like ligament laxity, bone mineral density, things that increase risk for injury in female athletes, but also increase risk for depression, anxiety, and eating disorders, which can complicate the recovery process. So I think it's important to note that when we're talking about some of these injuries, particularly things like ACL injuries, there's a really long recovery period. So this is, like 9 months to a year that someone potentially is out of their sport. And a lot of times what we're seeing when we're seeing athletes coming in for psychological services is that this is the first time they've been seriously injured. This is a period where there's a lot of uncertainty about what is the process going to look like. They have a lot of fear and anxiety about what they might be missing, where they might lose skills in their sport. Are other people going to get better than them? That they're not going to be able to compete at the same level as they were prior to injury. Fear that they're going to lose coaches' attention, that they're not going to make teams the next tryouts, etc. This kind of lingering worry about how this is going to impact the rest of their career, their season, and with that, a lot of grief, a lot of emotional sadness about thinking what they've lost, what their season isn't going to look like, and particularly around key developmental transitions that can be very difficult for athletes. So things like, their final season as a senior in high school, or potentially their transition to college, or their first competition season as a college athlete. These kind of transitions can make injury even more difficult for athletes to tolerate. It can lead to things like loss and isolation, which are all risk factors and complications of depression and anxiety. So often when we're thinking about how to care for athletes, we're thinking about not only what is important for their sports performance, how to make sure they're getting, their best performance in recovery to set up their kind of long-term mental toughness for return to sport. We're also thinking about the clinical conditions that these injuries put them at risk for, including anxiety disorders, depression, and eating disorders. Another key stressor for athletes in this time period post-surgery is hypervigilance around pain. So people may become really anxious about all pain being the same, pain signifying that they've done another serious injury, reluctance to feel pain, even though, especially for some recovery periods like the ACL recovery, pain is kind of necessary and part of that initial kind of straightening and bending the leg. Just kind of redefining what pain means during recovery is an important job of a psychologist helping someone through this process. And again, as we've already heard, there can be a lot of fear about re-injury and a lot of hesitation and potentially picking up strategies to prevent re-injury that actually put someone more at risk. So we've been talking a lot about female athletes, so it's important to consider the additional concerns that female athletes face. A large one is that a lot of female athletes do report pressures to achieve a certain body size, certain body type, to be as competitive in their different sports, and to just kind of be not to gain weight during the recovery period. So a lot of times we will hear athletes say, well, I don't want to gain weight since I'm not exercising enough. So there's a lot of misinformation about nutrition and what is required to be not just recovering well, but returning to sport and being ready to return to sport. And it's important to note that some of these ideas about what is adequate nutrition, what is supporting athletic involvement, is problematic even before injury, may have led to the injury. These athletes may have been prone to low energy availability. And again, as I was mentioning earlier, what that can lead to is people who have menstrual abnormalities. They may have low estrogen, they may not be cycling regularly, which means they're losing the neuroprotective benefits of estrogen. They're more likely to be depressed, have difficulties with rigid thinking, have challenges with anxiety, be more preoccupied with weight and shape, all of which are kind of cornerstone symptoms for anxiety, depression, and eating disorders, which, as Dr. Berkson also mentioned, are higher in female athletes. So what are we doing about it? Well, we've come up with a brief treatment approach that helps provide athletes with information about the recovery process. So part of it is just psychoeducation, helping people really understand what injury recovery looks like, the fact that adequate nutrition is necessary, and that sleep and nutrition and information help them battle negative moods, problematic thoughts, and just kind of emotion regulation in general. So we're doing a lot of assessment and understanding about the nutritional intake, referring to our nutritional colleagues when we think there might be something that's related to low energy availability. And then we're also giving them some strategies, particularly starting with things like mindfulness, which is involved in helping people stay present focused, focusing on one step at a time in recovery versus worrying about what might happen later. Dialectical thinking, being flexible in how they're thinking about their injury, noticing that they can feel many things. They can be happy that their team is winning and sad that they're not able to participate in those games that are contributing to those wins. So this idea of not being cornered into feeling a certain way about an injury over time. We're also helping people challenge problematic thoughts about needing to be progressing at a certain rate, comparing themselves to others with injuries that may seem similar but are quite different based on where the injury took place, their physical fitness beforehand, etc. We're helping people do exposures as they're medically cleared to do them, so they're gradually building up their confidence to return to sport. And we're also helping people build acceptance around themselves as something larger than an athlete, that they are an athlete but they are also a person in addition to that, and helping people find meaning in their recovery period, explore new hobbies, help that be something that is not just about them not being in their sport. So really briefly, I'm just showing you guys a couple of handouts that recovery is not linear. It's a big message. And again, these were helped prepared by our PT and nutritional colleagues that we share with patients to kind of help them get ready for working with PT and nutrition. Mindfulness, helping people remember thoughts, emotions, and behaviors are connected, and that they can change how they feel by challenging their thinking points. Things like thought restructuring, particularly around questions related to what they should be doing in recovery, failing to see important progress that they're making during recovery. And so take-home points. Female athletes do face unique challenges during their recovery period post-knee injuries. Assessing dietary information is necessary for adequate care of female athletes, and that athletes benefit from kind of this team approach that Dr. Berkson was mentioning, and from really taking the athlete in context and using empirically supported techniques. Thank you.
Excellent. Great. Thank you so much. So next up, we have Jamie Preszler. She is a doctor of physical therapy and also certified athletic trainer. Jamie has been doing a lot of work in pregnancy, which is one of, the unique aspects of being a female athlete that really, is deserves a lot of consideration and has been largely understudied. So she's going to be giving a talk today on the rehabilitation considerations for knee pain in the pregnant athlete.
Right. Okay, well, thank you, Dr. Tanaka. I'm going to be speaking on rehabilitation considerations for knee pain in the pregnant athlete. So as for knee pain, we know that female athletes are at a higher risk for knee pain and injury compared to their male counterparts. And patellofemoral pain syndrome leading to anterior knee pain is the most common cause of knee pain in the female athlete. And rehabilitation for female athletes with knee pain is effective when we focus on posterolateral hip strengthening, knee strengthening, neuromuscular training, and core stability training. So we understand that female athletes that are higher risk for knee pain and injury, and the musculoskeletal changes that occur during pregnancy may increase those risks. The prevalence in how we manage knee pain in the pregnant athlete has not been well described. And this is despite recommendations that encourage females to stay active during their pregnancy. Dr. Tanaka and her colleagues at Johns Hopkins found 26.1% of patients reported severe knee dysfunction during pregnancy, and that their knee function decreased with each trimester. So to keep our pregnant athletes active, we have to consider modifying the common exercises that we use to treat knee pain. And this presentation is going to be focusing on how we can do that safely and effectively. So ACOG updated their guidelines in 2024, and they continue to recommend at least 150 minutes of moderate intensity aerobic activity every week during pregnancy. And they also recommend, with approval from the athlete's obstetrician, that female athletes can continue working out at their pre-pregnancy level. So here are the objectives for this presentation, and I do want to emphasize that these recommendations and treatment guidelines are based upon the treatment of female athletes with healthy, uneventful pregnancies. So in the first trimester, the three major musculoskeletal changes that occur that directly and indirectly impact the knee are that the hormone relaxin increases in peaks, the pubic symphysis widens, and then there's an increase in ligamentous laxity. So in summary, the static stiffness from the ligaments starts to decrease, both in the pelvic girdle as well as the peripheral joints. So with that being said, the emphasis for treatment in the first trimester will be to work on that dynamic stiffness. And we're going to be focusing here on establishing appropriate activation of the muscles that contribute to lumbopelvic and hip stability, primarily the transversus abdominis, the pelvic floor muscles, and the multifidi. And I also want to comment on that during the first trimester, there are no specific precautions for PT exercise. So for our exercises, we're going to be categorizing the exercises by position, and we are also going to encourage co-activation of performing the exercises with co-activation of the pelvic floor muscles. And these are just some examples of some of the exercises we really like: the dead bug, side lying hip abduction, and the side plank with the clamshell. Now moving on to the second trimester, the musculoskeletal change that has the highest impact on our treatment approach during this trimester is that anterior shift in center of gravity. So if we think about the mechanics, the pelvis is going to start to rotate anteriorly, and therefore this causes an increase in lumbar lordosis, femoral internal rotation, and hip adduction. And this is in order to accommodate for the growing uterus and fetus. Now, we've seen this before in our female athletes that are predisposed to knee injury with this position of no return. So this change in body alignment in the pregnant athlete is going to make it more difficult to activate and strengthen the abdominals, the pelvic floor muscles, and then those muscles of the posterior kinetic chain. And then also during the second trimester, we should mention that the medial longitudinal arch also starts to collapse. And this increase in pronation is going to impact tibial rotation, which will then cause more rotational force at the knee. So these are the treatment goals for the second trimester. And one of the major precautions we need to start thinking about beginning in the second trimester is avoiding exercise in the supine position. And this is due to the potential for supine hypotensive syndrome. So in the supine position, compression of the inferior vena cava and aorta by the pregnant uterus can occur, which may lead to a reduction in the blood supply to the fetus. So now the positions we're recommending are, we're moving away from supine and hook lying, and we're recommending these four positions. And we're going to be building upon the foundation established in with the first trimester exercises. And just some examples of the exercises that we like. We like a lot of exercises in the quadruped position, and then the standing exercise using the band, promoting proper hip and knee alignment, as well as posterior kinetic chain activation. And then finally, the third trimester, the major musculoskeletal change we're looking at is weight gain, and this has a direct impact on our knee. So the goal for treatment in the third trimester is to continue with and progress exercises from the first and second trimesters in order to keep up with the demand on the lumbopelvic and hip musculature as the athlete continues to gain weight. Now, for precautions, during the third trimester, we're still avoiding exercise in the supine position. And we also want to make sure that our athletes are not holding their breath during their rehabilitation exercises. The Valsalva maneuver may reduce placental blood flow and fetal heart rate, as well as place undue strain on the pelvic floor muscles by that increase in intra-abdominal pressure. So here's a chart of some of the exercises that we're recommending in the third trimester. and just some pictures of the single leg fire hydrant, which is an excellent way to challenge balance, proprioception, neuromuscular control, as well as posterior chain strengthening. So precautions do lend to having their own slide, and this is extremely important when working with this patient population. So safety is always a high priority when we're working with our patients, and in this case, we have both our athlete and their unborn baby to consider. So once again, I want to emphasize that these recommendations and treatment guidelines are based upon the treatment of athletes with healthy and uneventful pregnancies. And if your patient experiences any of the following symptoms, exercise should be discontinued until they're able to follow up with their obstetrician. So in summary, the musculoskeletal physiological changes that occur during pregnancy that impact knee rehabilitation are follow in the following bullets. And then exercise and strength training are important for both maternal and fetal health. And rehab exercises that we commonly use to treat female athletes with knee pain can be effectively and safely modified during pregnancy. And since I've just touched on these rehab considerations, I've included the link to the manuscript that Dr. Tanaka and I published a couple of years ago if you'd like more information on this topic. Thank you very much.
That's great, Jamie. Thank you so much for that useful information. And I think this is an area that's going to continue growing and continue to see a lot of interest going forward. So next up, we have Ashley Wiater, who is also a doctor of physical therapy. She has done a lot of work in the injury rehab and prevention space. And so she's going to be talking about sex differences in ACL injury rehab and prevention.
Thank you, Dr. Tanaka, for having me today. Pleasure speaking along all of you. It's a pleasure to be here. Dr. Berkson did such a phenomenal job starting us off today. So a lot of my initial comments with regards to the non-modifiable risk factors that we see in female athletes, the risk in general for an ACL injury, which again is anywhere from 2 to 10 times higher than males. I will be a little bit more brief on because he did such a phenomenal job highlighting these, but there's things that again are outside of these athletes' control, things like playing surface, their training levels, their shoe wear. These are obviously things we can have input and say on, but these are typically the things we're not going to be addressing. Intrinsically, there are also things that again we may not be able to change or fix, again, like some of those non-modifiable bony changes that Dr. Berkson again touched on, but there are things that we can, and that's obviously where, especially in the PT world, that we can have a major impact, not only to prevent injury, but also to prevent a re-injury or another ACL tear, another knee injury down the line. So again, just highlighting the things that we're going to see as non-modifiable, those bony changes, the hormonal changes that were touched on, genetics now even that we're seeing within family members having risk of another individual within the family having an ACL injury. And then there's going to be the modifiable factors that again are where the PTs exist and hopefully can make the biggest impact and changes on the field. So again, just highlighting some of the bony changes we might see in the female versus our male counterparts. Basically, a more steeper tibial slope, a more narrow notch where that ACL is coming through, a smaller tibial spine on attachment here. Again, we're not going to be addressing or changing these, but we might be having these conversations with athletes as to why they might be at a greater risk. Why do we care so much about making changes to the things that we can? Because ultimately, there's things that we cannot impact. Our alignment, typically these females have maybe, females in general have wider hips than at their knees, so a greater Q angle. Many females might be more lax than their male counterparts. We might see this with the positive Baitens when we assess them, and just generally has less joint stiffness when we're assessing them on the table. And then with the ACL themselves, they're smaller tissue, so less width and length, less volume. They need less stress to tear. So again, these are all things that we're going to maybe have discussions with the athletes, especially if they're returning back from an injury or returning back from an ACL surgery. Again, these are going to be components that we're going to be considering when and why we're emphasizing the things that we can, i.e. those modifiable factors. And just to touch base briefly on some of the hormonal components that were already discussed, but there's mixed evidence out there as to at what point in the phase we might be most at risk and to what extent, to what level or stress there is on the ACL at different times during an athlete's menstrual cycle. And there's also different components as to how we might address it, whether that's utilizing oral contraceptives for certain athletes. Again, again, there's evidence that continues to grow in this area, and I think it's an area of continued interest, especially again with the volume of ACL tears that we see in females. And I think it's an interesting area of focus too, because again, while it's something in theory that's happening outside of the athlete's control, if there can be ways to impact this with use of whether it be contraceptives or other components that were addressing the level of estrogen, it could be an area of interest in the future. During that pubertal stage, we're seeing a greater change or greater spike with the female athlete versus their male counterpart. Again, they're not obtaining the same level of strength or joint stiffness that their males are when they go through these major changes. So they become longer and leaner, but they don't have the strength to necessarily match it. So that's why you see such a greater spike with knee injury and ACL injury at a younger age or during their puberty with females versus males. So again, just keep that in mind when we start to think about some of the strength training and strength assessment. We're just not, as females, we're not keeping up with the same level of strength as the males are. So with the things that we can change and we can impact, this is a very common scenario that we'll see in the clinic, whether it's pre-injury or even post-injury. So I'm oftentimes seeing this not only on an ACL injured or affected side or post-surgical side, but I oftentimes see this on the non-surgical side. So it's why I really emphasize to the patients that I want to address and look at deficits for both limbs. I oftentimes will have the discussion, I don't want to see them back for another ACL tear, but this is a common scenario where someone has a stiff limb, they're not able to absorb forces, they're compensating at the trunk. You'll see hip internal rotation here, some of this knee valgus, and pretty much here she's just not able to absorb those forces. She's not able to control the load as she comes down and land. You see that obviously with a really stiff knee at landing. So again, you'll see many different compensation patterns, but this is a very common one that we see, and she clearly doesn't want to load into that knee. And why this typically is more common with females is we're more quad dominant, we're not getting that co-activation with the hamstring, we're going to be weaker potentially in our hips and our glutes, which we'll talk about in terms of assessment. And then going through puberty, we're going to have less of this control as a whole. So again, these are commonly seen patterns that we'll see pre-injury, and if we're assessing them at preventative stage, but also post-ACL or in the rehab phase, getting them to return back to sport, I'll see this on both limbs. So how do we help and how do we fix this? So biggest first step is assessing the strength. So from as seen here with the dynamometer, if you have access to an isokinetic machine, it's another great tool. There's actually a number of different devices out there now that are more accessible for outpatient clinics that can be utilized, but we want to get an assessment of their strength. So absolutely a quad hamstring assessment, looking at the comparison from the quads to the hamstrings, whether it's a 2-to-1. There's evidence that's mixed up there with regards to what that ratio should be, but if your hamstrings are a quarter or less than that of the quads, we know we got to do some work on the posterior side. Hips especially need some extra attention within our female athletes because of that wider Q angle that I talked about, and generally a weaker area in females compared to males. We want to make sure we're assessing and then also strengthening those areas to help control some of those frontal plane maneuvers we saw in the video. And then one of the areas I typically will really highlight, because I think it gets missed a lot, is looking at the foot and ankle and what that gastrocsoleus complex can do to help absorb forces. I think it took me a couple years into my career to realize how important that can be in absorbing and landing, but it's an area that I'll absolutely either assess or at least a comment or make sure it's a part of the home program to really help emphasize and control those forces as they come down. And then lastly, we can't forget about how much that core plays a big role in controlling throughout the whole chain. So making sure whether it's a program that you give them for home or within the clinic, that the core is absolutely being addressed. As we talked about, we want to look at those strength deficits if we find them with assessment, making sure the appropriate ratios exist, controlling for that frontal and sagittal plane movement that we saw in those videos. Someone might have no knee valgus or the knee's not collapsing, but if you look at it from the side, they're not bending the knee at all. So making sure we're addressing any deficits in any of the planes to make sure they can go out on the field and control that knee appropriately. And then that also comes down to prepping them for those environments, right? If we're just doing setting, a single leg hop, very controlled. We haven't really done a good job in preparing them for the field. So making sure as much as we can in a clinic setting, preparing them for a more chaotic environment. And that comes down to potentially challenging them with other cognitive demands or basically a multitude of other ways to challenge their cognitive load during simple or more complex tasks. And then lastly, just making sure we're individualizing each program based on their demands, based on their needs, what their deficits may be when we first assess them, and knowing that there's things that we cannot change, but there's things that we absolutely can, and it just puts a greater importance on that. And then making sure we're utilizing any type of testing measures that we have access to. Again, there's a number of different variety of testing available out there, much more accessible these days. And then lastly, looking up and down the whole chain so we don't miss a component that can really help keep them safe on the field. Thank you.
That was excellent, Ashley. Thank you. So as she covered, it's so important to understand just the nuances of this. And so it's really, we're really lucky to have people like Ashley who know so much about this to help us treat our patients and also to be working on prevention as well. So to round out the talks, lastly, I have Olivia Morgan. So she is one of our star nutritionists who has barely been helping us kind of focus on the nutrition considerations with our post-surgical patients, among other issues. So she's going to be talking today about nutrition considerations for recovery after knee surgery in the female athlete.
All right. Thank you so much for having me today. So I am Olivia, and today we're going to be talking about some of those nutrition pieces. So it is really rounding out the talk today because we kind of went through a bunch of things that I kind of wanted to touch on. So I can just talk about my piece, which is food. So I'm going to talk about a little bit about meal timing, protein intake, which is the hot topic of the day, micronutrient considerations, and just kind of a little bit of a rounding with kind of some food as medicine kind of talk. So before I get into that, I really like to use this pyramid to discuss priorities when it comes to nutrition, especially with our female athletes and our injured athletes. Energy balance is the most important piece and the most challenging piece because a lot of times our athletes are used to a certain level of activity and they're not able to do that level of activity at this time. And it can be really challenging for them to kind of adjust their mentality. In recovering from surgery, we know that our energy needs are definitely increased. So that is something that we just have to be really thinking about. Moving beyond that, we have to think about our macronutrient distribution. Like I mentioned, protein is the hot topic of the day, but carbohydrates and fats are other options that we need to make sure that we're hitting those marks as well. You wouldn't believe the number of patients that I talk with that are eating hundreds and hundreds of grams of protein and no carbohydrates and putting no oil on any sort of the vegetables that they're roasting. So you have to really dig deeper in making sure that we're hitting all of those points. Then we have to think about how we're spacing out our nutrients throughout the day, making sure that we're getting what we need at the time that we really need it. And then finally at the tippy top is more of those supplements and micronutrients, which are definitely extremely important for recovery, but it's not my biggest focus because we need to make sure that we have our energy balance and our macronutrients in place. And then that usually makes sure that our micronutrients are following. And supplements are really just the icing on the cake. They shouldn't be taking the full place of all of our nutrition pieces. So touching a little bit more on meal timing. So this is just trying to make sure that we're meeting our energy needs to prevent that low energy availability, prevent us from getting in a state where we don't have enough fuel in the tank to continue our healing process. So with my patients, I really like to encourage them to start early. So really aiming to have a breakfast within 90 minutes of waking. That can be challenging for some people. Sometimes breakfast doesn't really look the same. Sometimes it's really just trying to get something in to get the day started. And then kind of continuing every couple of hours, making sure that we're getting in some sort of meal, snack, or kind of eating opportunity. Kind of gives it a little bit more of a blank slate for our patients. I always emphasize that all of our eating opportunities should have a source of protein as well as a source of carbohydrates, just because that makes sure that we're getting that quick energy as well as that longer term energy and kind of that appropriate fuel for that muscular recovery. And one other important point is to really treat our physical therapy sessions more like our training sessions. So some of the exercises that were being described, involve a lot of brain cognitive thought as well as physical effort as well. I want to make sure that people are treating those sessions respectfully and having a snack beforehand and then refueling afterward in a similar fashion that they would normally do for their typical training. So, we treat our PT like we would treat our usual training sessions. So talking more about protein, again, the hot topic of the day, everything in the grocery store has additional protein in it. Our protein needs are definitely high in this population, right? We're healing, we're recovering. We want to make sure that our tissue heals. We want to make sure that we're maintaining our muscles, we're healing our wounds. The needs are pretty similar to what an athlete would expect. In the hospital, we often use 1.5 to 2. In an outpatient basis for an athlete, we use 1.4 to 2 grams per kilogram. We don't often ever go above 2 grams per kilogram for an extended period of time. It's just not really needed, and it tends to mean that we're sacrificing other macronutrients. One other piece that I like to really highlight is the time of pre-sleep protein. There's been a little bit more research kind of showing that we have an increased ability to uptake protein before we go to bed. Even up to 40 grams of protein, where normally we're looking at 20 to 30 most eating opportunities, especially where we're going to be doing a lot of recovery while we're sleeping. And it can be a great window just to kind of push the day a little bit over and make sure we're hitting all of those macronutrient needs. Then getting a little smaller in the nitty gritty, we want to think about micronutrients. I do want to mention, if we do have the opportunity for surgery to make sure that we are correcting for any deficiencies. With our female athletes, we tend to see a significant amount of iron deficiencies, usually presenting as a low ferritin, just something that is not always looked at, so always good to check in. I've seen a lot of B12 deficiencies and obviously vitamin D as well, just because of the region that we are in. So making sure that we don't have any of those in place, because we want to optimize our healing, because healing does require a little bit more of every micronutrient. If we're involving any sort of bone, we want to make sure we're trying to encourage 3 high calcium foods per day. If that's not possible, then always refer to a dietitian, because I can always help them out. And then thinking wound healing specifically, we do have increased needs of zinc and vitamin C. In general, a lot of these things can be accomplished with diet. For correcting for deficiencies, usually going to need some sort of supplement, but otherwise going to be diet, maybe a multivitamin, just to kind of cover our bases. That's because the supplement world is a wild, wild west. We need to make sure that if we are using any sort of supplement, that it is third-party verified, meaning that there's an additional safety level in there. Finally, touching briefly on just kind of food as medicine, there are some foods that we know are more anti-inflammatory. As Kendra mentioned, people can become really rigid in their thinking, so I really just kind of encourage variety for a lot of our patients. So we know that our omega-3 rich foods, our fatty fish, our nuts, our flaxseed, those can be really anti-inflammatory. Getting a phytochemical rich foods and a variety of fruits and vegetables, deep and rich in color. All of those have different kinds of benefits. Sounds really simple, but it really does have a long and lasting impact. And kind of thinking about that point, it definitely encourages us to be getting more fiber as well, which is really helpful for preventing any constipation. People aren't maybe doing as much activity as they're used to, so their GI system may be a little bit slow. So I love to encourage prunes and kiwis, but you do have to eat the skin. So that can be a tough part for some people. So just a few takeaways to kind of close it out. Most important for me is eating consistently. The body loves consistency. Getting protein throughout the day, variety of fruits and vegetables to kind of cover our micronutrient needs. Maybe consider a multivitamin, and energy sufficiency above all else. Absolutely the most important key. All right. Thank you so much, everyone.
Thanks, Olivia. That's great. I think I'd rather take a supplement than eat the kiwi with the skin, though, for me. So we do have some questions that are coming in. So thanks for all our speakers for having your video on for the panel discussion. So one question, let's see, who are we directing this to? Okay, the question is, how does the menstrual cycle impact recovery timelines or outcomes? What are the biomechanical and hormonal changes? Oh, how do biomechanical, this one, Jamie, is for you. How do biomechanical and hormonal changes during pregnancy alter knee loading patterns? And what implications does this have for postpartum return to sport?
Okay, let me see if I've got all that.
Yeah.
So let's see. So let's chat about that, the anterior shift in center of gravity and kind of the cascade that happens as the pelvis starts to rotate anteriorly. So that is essentially the driver for just more of that femoral internal rotation, hip adduction. So it's tibial internal rotation. So it's driving this these increased rotational forces on the knee. So that's really, so there's that piece, that mechanical piece, and then also the lack of static stiffness from the ligaments, both in the pelvic girdle and then in some of the peripheral joints. So we're now having to depend more on our dynamic sources of stabilization, which are the muscles. So that is where that increased rotational force at the knee is going to be most impacted. And then that's a really good question about the postpartum piece. So I didn't dive into this much, but one of the other benefits to encouraging our female athletes to stay active during their pregnancy is that during the postpartum phase, their strength, their stability, their ability to recover is improved. It's more, there's going to be earlier return to sport and return to activity if they've been able to stay active, stay strong during their pregnancy. We've definitely seen that. So I think that answers that part of the question about the postpartum phase. But yeah, so activity during pregnancy, teaching them how to activate and recruit these muscles properly, keeping them strong, keeping them active so their knee pain doesn't disable them from staying functional and staying active. And then we're going to see a quicker recovery of their activity in the postpartum phase.
Yeah. Great. Yeah. So to kind of sum up, like, I think you're talking about the shifting of the center of gravity that happens, the increase in weight also that changes the loading of the patellofemoral joints, all of those things can contribute. And then the next question, I think this will go to Ashley Wiater and Eric Berkson both. From a surgical outcomes perspective, are there any rehabilitation strategies that significantly improve graft survival in female patients?
I'll start and simply state strength. So
Yeah.
the best thing I can do and the best way I can assist is to get them stronger. If I have some preoperative strength values, that also helps gauge as to if I'm going to make improvements for them. And I use that as almost a real positive for them, because if I can show them such improvement in strength for both sides as they return back to sport, to kind of touch on what Dr. Becker mentioned, I mean, these are great ways I can show them that they're going to be safer and potentially better going back to the sport, and even from a better performance level. And then lastly, being able to address any of those neuromuscular deficits that I'm seeing on both sides in these athletes, that's where I'm going to help the most.
Great.
I would just add that this is the whole idea is that you have to have a great rehabilitation strategy after this, and that's probably more important than the surgery itself. And this starts really way before surgery, and it's the comprehensive effort afterwards, which is really focused on that recovery.
Yeah, and to that point, maybe Eric, you could talk a little bit about, because I think a lot of surgeons obviously treat both men and women, and you're kind of experienced in this area, but maybe you could talk just a little bit about like what you specifically do that's a little bit different for your female athletes before surgery, like in the, pre-operative phase, whether it's the discussion or preparation, and then what sort of things you think about during surgery, and then what might be different, afterwards as well.
So before surgery, this is understanding the patient. It's referring and making sure that they're touching base with their physical therapist and the nutritionist beforehand, and even talking to a sports psychologist beforehand. I think that that female patients, just like any patient, benefits from a better understanding of the predisposing factors that led to this, and then to some of the decision makings. I think we don't give our patients that much control about what happens during surgery, but graft choice is one of those things that they actually do play a role in picking, and having a really meaningful discussion about what are the benefits and risks of each different type of graft choice, and how that can particularly affect them. Intraoperatively, the surgery is the same surgery, but you need to be considering the size of the patient and their neuromuscular demands and what they're going back to. I like paying specific attention to how much impingement is going to be at the notch, the size of the graft, and the shape of the graft to help that, and then really making sure that this is as anatomic a surgery as it can be. We gloss over little things like the meniscal injuries, but the meniscus helps protect against the shield and shield the ACL, and it becomes even more important when you have tibial slope problems that are contributing to that. And adding that LET, or that lateral extra-articular procedure that can help shield the ACL during its initial phases of recovery, I think is essential for women, especially anybody that's at higher risk and has higher ligamentous laxity and contact sports, and getting back to that. And then postoperatively, it's really making sure that the physical therapist understands where everyone is going to at the end, and how to track that, and measure performance and recognize success along the way, and then making sure that we're not just recovering from this surgery, but we're preventing the next injury. The risk of injuring your contralateral knee is probably bigger than the original knee by the end of the recovery.
Yeah. No, that's great. Those are some great points. Dr. Becker, you talked, about the recovery process, and of course, you've been kind of leading the charge on this new recovery sort of program after ACL surgery, especially for our female athletes. Can you just talk a little bit about, what that's been like? What are the considerations, how that's going, and kind of the insights that you've gained so far from this program?
Oh, absolutely. I think what it's really challenged me to do is something that everyone has been speaking about, kind of in their separate fields, which is to be thinking of the person in context. So things that, I might not have considered before taking on this role, or the type of sport. What is their end goal? Like, what are they trying to return to sport? Is this a second injury? Like, what is their mind state? Kind of what are their goals? For the entire recovery period. How old are they? All the things that, maybe I wouldn't have been thinking about when I wasn't treating athletes. I think that this is a specific population. They're a special population. There's things that, when developing this program and thinking about a return to sport, or just ACL recovery in general, it's important. I've learned to be thinking about that. Like, what are they, kind of what is each individual person bringing to their recovery program? No one's is the same. We may have, some general messages we're giving, like recovery is not linear, like all pain is not the same. Go to your PT, like these types of things. But what I'm learning is that no athlete is the same. No no injury is the same. I think something that comes up so frequently with the patients I've been working with is this comparison trap. Like, so-and-so had this injury and they were back in 5 months, and like, I'm barely doing this. And so being able to have those conversations competently, I think I've learned also to be in collaboration with the team members. I think really important in this is this team approach, and not taking on the nutritionist role or the PT role, but being able to support the messages that are coming from these providers and helping athletes understand and be prepared and challenge thoughts that get in the way of their full participation with all of their providers is really relevant. Thinking about what questions they want to ask their surgeons, and kind of helping them be advocates for, letting, folks know about what pain or what experiences they might be having during their recovery process. So I think, so to answer your question, like, those are some of the insights I've had, but I've also really enjoyed it because it is, again, not every athlete is the same. I have also gotten to learn a lot about different sports that I never played before. So I think that's also something that's been rewarding for me in this work too.
That's great. Thank you. And then in the last few minutes, Olivia, I was hoping, I think a lot of us don't necessarily get the training and have the knowledge on really anything related to nutrition, at least from our field in orthopedics and probably many others. And you kind of commented on the importance of not being energy deficient. So what advice would you have for clinicians, who might be trying to assess whether somebody's energy deficient? Like, how would you tell a patient or a clinician, like, what should you watch out for, and how do you know when someone's energy deficient?
Wow, that's $1 million question. I feel like with a lot of my female athletes, I'm coming from the perspective that I'm assuming that we're a little underfueled until proven otherwise. So I have to be pretty convinced that we are fueling appropriately. Especially my folks who I'm seeing, repeat offenders, repeat customers, in terms of injuries. I'm assuming there's some level of deficiency. And even with my people who, think that they're doing great, they're doing the pre and post exercise fueling, there's often things that we do need to address. Carbohydrates are super feared right now. People are really overemphasizing protein. And I think especially in our younger athletes who are still growing, I get a lot of parents like, well, they're not eating enough protein, blah, blah, blah. Carbohydrates fuel growth. And a lot of times, parents are being a little limited of kind of the carbohydrate options that are available because of some messaging that they're seeing, from kind of their perspective. And that really translates over to the kids. Another thing is just that, what people say, around food and bodies definitely matters. And people can really internalize even tiny little comments over time, and it can cause them to restrict or think certain things. The doctor said this, the PT said this, to both a positive and a negative. So if everyone is kind of on the same page of like, we really need to be fueling appropriately. We need to be eating often. You're skipping breakfast. Oh, let's talk about that. Oh, you can't eat before your workout because it hurts your stomach. Oh, maybe you need to talk to a dietitian. So if everyone's kind of on that same page, then it's a really easy kind of flow.
Great. Well, I think we are coming up on the end of our hour. I'd like to thank all of our speakers today, who are just amazing colleagues to work with in the Women's Sports Medicine program, who really are together really driving the field forward for female athletes. So thank you so much for your time. I'd also like to thank our audience members. It looks like we had 305 members from 47 countries attending today. So that is exciting to, continue this sort of international exchange with this sort of discussion. And I am also supposed to announce that there will be a re-live or replay of this webinar that will be available on arthroschool.com within the next 24 hours. So thank you, everybody, for today.
Tap like, subscribe, and hit the bell for instant updates. you.